Good morning, everyone. So we are going to be discussing the Partograph today. And by the end of this session, hopefully everyone will be able to give the principles behind the use of the Partograph. And then you will also be able to plot one, interpret a Partograph, and give the advantages and the advantages of its use. So let's start. So basically, the WHO approximates that almost every year, about 210 million women get pregnant. And out of this 210 million, about 20 million of them will experience pregnancy-related problems, which is a very huge number. And then out of all these numbers, about 500,000 of these women die from complications of pregnancy and labor. And then the main problem here is about 99% of these deaths occur in developing countries. And Nigeria is a developing country. But then the beautiful thing about all these things is that most of these deaths are preventable by managing labor appropriately. So it's very important to know how to manage and handle labor appropriately. So of all problems, prolonged labor in the developing countries is mostly caused by two main problems. And these two main problems are ineffective uterine contractions and obstructed labor, which can be very well prevented. For example, if you figure out that this woman is having an ineffective uterine contraction, you can easily augment the labor and ease this woman's problem. Then in the case of obstructed labor, cephalopelvic disproportion is the commonest cause of obstructed labor. So when it remains undiagnosed and untreated, it can result in several complications. Some of these complications that can occur as a result of obstruction include maternal dehydration and exhaustion. And the last thing you really want in a woman who is in labor is dehydration and exhaustion. So another complication that can occur is uterine rupture. Then she can develop vesicovaginal fistula. There can be maternal and neonatal sepsis. Postpartum hemorrhage can occur. So these are all complications that if you really know how to diagnose and manage labor appropriately, you can prevent all of these conditions from happening. So what is a partograph? A partograph, like we all know, is a graphical representation of the events of labor. And the partograph is mainly used as a tool for prevention of prolonged labor. So regarding all those complications that I earlier mentioned, so it came to conclusion. A conclusion was made that early detection of abnormal labor and prevention of prolonged labor will reduce the fatal and non-fatal complications of obstruction. And therefore, Partograph was designed to show the progress of labor at a glance, and therefore indicates when augmentation or termination of labor is indicated. So the Partograph is designed in such a way that once a woman is in labor and the Partograph has been opened, just by taking the paper and looking at it, you'll be able to figure out if the labor is going how it should go, or if there's a problem. So this is a picture of a Partograph. It has several components, but this is a pictorial representation of how the Partograph looks. So it has several components, which we will discuss one by one. So the Partograph mostly has three main parts. There is the fetal record or the fetal component. Then there is a part that shows the record or the progress of labor, and then there is the maternal record or the maternal component. So if we take the record of progress of labor, this is the most important part of the Partograph, and it consists mainly of cervical dilatation, which is plotted against time. So if we go back and look at this, so this here, is the progress of labor. As you can see, this is the part where you have the cervical dilatation, and it's from 0 here to 10. But mostly, since you don't open the partograph until the woman is in active phase of labor, and that is at 4 centimeters cervical dilatation. So you start plotting from 4. That is when the woman enters the active phase of labor. So this is about the cervical dilatation. So the main features of this part of the progress of labor, we have the active phase, then we have the alert line, which starts from time 0, and then there's the action line that starts from 4 hours to the right of the alert line. Then we have the time axis, the cervical dilatation, level of descent of the head, and frequency and duration of contractions. These are all parts of the partograph that are a record of the progress of labor. So like I mentioned earlier on, you don't open the partograph until the woman is in active phase of labor. Initially, partographs had parts where you can plot the latent phase of labor, but nowadays you don't plot the latent phase, you only start from the active phase of labor. So the alert line this here is the alert line. And then 4 hours from the alert line to the right, you have the action line. Then you have the cervical dilatation, like I already mentioned. Then you have descent from 0 to 5. Then you have the part then downward, you have the part where you record the contractions, which is here. So these are all components of how you assess the progress of labor. And then, so what is the active phase of labor? Like I earlier mentioned, on the active phase of labor, a woman in labor is said to be in an active phase of labor where she has reached 4 centimeters cervical dilatation. And the active phase of labor ends at full dilatation, which is 10 centimeters. So you are expecting at least 1 centimeter cervical dilatation each hour when the woman enters the active phase of labor. So, and this alert line represents that 1 centimeter per hour dilatation and is drawn from 4 centimeters upwards at 10 centimeters. So you start plotting from 4 centimeters. At each examination, you assess how much cervical dilatation she has achieved. And it should keep increasing with at least 1 centimeter per hour. It shouldn't be lower than 1 centimeter per hour. So the cervical dilatation, if cervical dilatation of a woman is lower than 1 centimeter per hour, then you'll figure out that the graph starts moving to the right of the alert line, not to the left. It is actually supposed to be on the left of the alert line. So if the labor is going progressive, if it is progressing, well, the cervical dilatation is supposed to be going this way. If it was 4, and then at another examination you find out she's like around 7 centimeters, so it should be to the left of the alert line. But let's say if you examine again and then you find out that after 4 hours, this woman is still at 6 centimeters. Then you examine again, she's still at 6. So it starts going towards the right of the alert line when it is actually supposed to be within the left of the alert line. And then the major problem arises when this goes towards the action line or it goes beyond the action line. So you want it to remain to the left of the alert line. It shouldn't go to the right of the alert line or towards the action line. So once you figure out that the cervical dilatation is going at a rate that is slower than 1 centimeter per hour, and then the woman that is in labor is in a primary healthcare facility, and you know that you don't have the necessary equipment that if a complication should arise, you can be able to manage this woman, you should start preparing her for transfer. You should prepare that woman to be transferred to a hospital where she can receive the appropriate care. And that is why the action line is 4 hours away from the alert line, so that it will enable you to transfer that woman from your primary healthcare facility to a tertiary facility where she can receive the appropriate care. But and then if the cervical dilatation reaches or crosses the action line, a critical assessment of the cause of delay must be done, and appropriate management should be instituted, like I already mentioned. So we've mentioned the active phase, we've mentioned the cervical dilatation, now the descent of the head. The descent of the head, and then of course you assess your cervical dilatation via vaginal examination. Once you admit the woman, and then 4 hours from the last vaginal examination, you do it 4 hourly, and it is purely an aseptic procedure, because you don't want to introduce infection to the woman or to the baby. And then for the descent of the head, this is determined via abdominal examination. You place your palm up on the lower abdomen around the pubic area, and then so you begin to palpate. Once you, by the palmar surface of your fingers, if you are able to feel the head completely up and it covers, just like it is demonstrated here. So you put your palm, and then if you can feel if all your 5 fingers can feel the head, then it is said to be 5.5 or completely above. It is not in the pelvic cavity. Then if only 4 of your fingers are palpable, then you know that the synsput is high. This is the synsput is high, while the occiput can be easily felt if you do your VE. Then if it is said to be 3/5, when only 3 of your fingers can feel the head of the baby, then 2, 1, and then 0. When it is at 0, then it has completely gone down and none of the head is palpable per abdomen. And then on the partograph, you do not descend by a cycle. You cycle. While cervical dilatation, you do not it by a cross or a plus. Then the other component is the quality of the uterine contractions that the woman is having. So the frequency of uterine contractions is the number of contractions that the woman is having in 30 minutes. You monitor uterine contractions every 30 minutes for 10 minutes, and you count how many contractions is she having. Normally, she should have 2 to 3 contractions. Some say 3 to 5 contractions in 10 minutes. Then the intensity of the contraction, it can either be weak, medium, or strong, depending on how long those contractions are lasting. So if the contractions are lasting less than 20 seconds, if they last less than 20 seconds, you denote them by making dots as demonstrated here. So if someone should look at that Partograph and sees dots, then of course they know that this woman is having weak contractions. And then if she's having 2, so you shade 1, 2 boxes. And then if she's having 3, you shade 1, 2, 3, making your dots. And then if her contractions are lasting 20 to 40 seconds, then you make strokes like demonstrated here. And then if the contractions are lasting more than 40 seconds, then you shade the box completely as demonstrated here. So that is about the progress of labor. Then now the fetal component or the fetal graph of the partograph. This consists of three components. You have the fetal heart rate, the state of the liquor, and molding of the head. So about the fetal heart rate, it is denoted on the partograph with a dot. And on the partograph, on some of the partographs, you have a preset line that represents the normal range of the fetal heart rate. With the normal range should be 120 to 160 beats. So in some partographs, like in this one, this is the old partograph which had the fetal heart rate from 100 to 180, but now it has been revised and the normal heart rate is 120 to 160. So the preset lines I'm talking about, these are the preset lines I'm talking about. So this is to show you that anything above or anything below these preset lines is abnormal. As long as you see that you are going below this line or above this line, you should know that there's a problem. So any heart rate outside the range of 120 to 160 is abnormal. Then the state of the liquor. So once you examine the vaginal examination, you should be able to indicate whether the membrane is intact. If the membranes are intact, then you denote it on the partograph with an I, meaning membranes intact. And this is where you plot this is where you plot your amniotic fluid findings. So if it is intact, you just write an I. If it has ruptured and the color of the liquor is clear, you write C. If it is blood stained, you write B. If it is meconium stained, you write M. And at each vaginal examination, you assess and denote your finding. And then for molding, this is where you document your molding findings, whether it is 0, +1, +2, or +3. And we'll look at how you grade molding. So this is about the state of the amniotic fluid. You can either say it is intact, or it is absent with an A, or it is bloody with a B, C for clear liquor, and M for meconium stained liquor. And then we have molding. Molding, it is in grades from 0 to 3 to +3. So it can either be 0, meaning that the bones, the parietal bones, are completely separated and the sutures can be felt easily. +1 is the bones are touching each other. They have approximated and they are close to each other. Then +2, the bones are overlapping, but once you put your finger in between, you can easily separate them. So that is +2. Then +3 is the bonds have completely overlapped. Even if you put your finger, you cannot reduce those bonds. They have completely overlapped. So based on that, you write, based on your finding of vaginal examination, you denote whether it is 0 or 1+, 2+, or 3+. So that is about molding. And then now the maternal condition. Of course, you will not forget the mother as you are assessing the baby. So the items that need to be recorded on the maternal condition include the pulse rate, which you will be taking every 30 minutes, then temperature as you finish your vaginal examination every 4 hours, then blood pressure every 4 hours, or more frequently, for example, if the woman is hypertensive, or if this is a woman with preeclampsia and you are allowing her to go for spontaneous vaginal delivery. Of course, regarding the condition, the condition will determine whether you will follow this 4 hourly or you will revise it to maybe hourly or 2 hourly. Then, of course, you check the urine output every 2 to 4 hours, and then you look for the following parameters, which are documented on the Partograph. We have the volume of the urine, which you will write, whether whether there is acetone in the urine or there are proteins in the urine. So this is about the maternal component. And then, of course, there are columns for drugs and IV fluids that are given. Like I mentioned earlier on, you don't want to give a woman, you don't want to keep a woman who is in labor dehydrated. You don't want her to get exhausted. So of course, you are going to help her with IV fluids, and then you can give her analgesia. Like we all know, labor should not be a painful experience. So give that woman analgesia. You can give her pentazocine, it could be pethidine, but whatever you give that woman in labor, there's a column for you to document. Document the drug, how many milligrams you give her. And then if, let's say, for example, that woman was not having adequate contractions and you decided to augment the labor with oxytocin, there's a column for oxytocin as well. You write how many IU, how many drops, in how many mils of fluid did you put the oxytocin. So you record the number of units you give the oxytocin per 500 mils or liter in the appropriate box. And then you indicate the number of drops. So let's say you are giving her 5 IU of oxytocin in 500 mils. So you write 5 international units of oxytocin in 500 mils of Ringer's lactate. Then you calculate at how many drops do you want to give her? Do you want to give her 10 drops, 5 drops? So you write at 5 drops per minute. You document it that way. So what are the indications for the use of the Partograph? You don't open a Partograph for a woman who has a gestational age of less than 34 weeks. So the woman must reach 34 weeks of gestation before you can open a Partograph for her when she's in labor. Then for women who are admitted in labor with one of the following, either she presents to you in latent phase of labor because you did vaginal examination and the cervical dilatation is 3 to 4 centimeters, less than 3 to 4 centimeters, but she's having regular painful contractions. You calculated at least 2 in 10 minutes, and they are lasting at least 20 seconds. So if she's having this painful uterine contractions, you can open a Partograph for her, but advisably, you should wait for her to enter the active phase of labor. Then you can open Partograph for a woman also who is in active phase of labor. That is, she has reached cervical dilatation of 4 centimeters and she's having regular painful contractions. And then, of course, you open Partograph also for women with spontaneous rupture of membranes, but who have no contractions. You can only open Partograph for these women when you start oxytocin, you want to augment the labor, or when the labor commences. But when she just comes to you and tells you that my membranes have ruptured and she's not having any contractions, she's not having any signs of labor, you don't rush to open Partograph for her. You only open the Partograph when you've given oxytocin to this woman to augment, to induce the labor, or when the labor has already, or when the labor commences. And then you also give women, you open Partograph for women who you have induced when you do ARM with or without oxytocin. So the moment you do ARM, you open Partograph for them. And then women who have undergone medical induction, either with oxytocin or prostaglandin or with catheter, when you induce them and they have started going towards labor, then you open Partograph for them. So what are some of the contraindications to the use of the Partograph? The Partograph, of course, should not be used for any woman who has not reached cervical dilatation. For a woman who has reached cervical dilatation of 9 to 10 centimeters, When she's already 9 centimeters dilated, what are you opening the Partograph for her to do? The woman is just going to start pushing, and before you know it, the baby will be out. So you don't need to open Partograph for her. And then women who you have already scheduled for emergencies for elective CS. If the woman is going for CS, then you don't have to open Partograph for her, because Partograph is only for women who are going for spontaneous vaginal delivery. Then you don't open Partograph also for a woman who is going for emergency CS immediately on admission. For example, this woman came to you and immediately they entered the labor ward. It was abruptio placenta, and you know that you are going for emergency cesarean section. So why waste time to open a Partograph for her? Or maybe she came with cord prolapse or something that you need to quickly rush to the theater for emergency CS. So you don't have to waste your time to open a Partograph for her. Then, of course, a patient with gestational age of less than 34 weeks, less than 34 completed weeks, you don't rush to open Partograph for her. So what was not included in this slides is the advantages. So it helps you in having a glance at the progress of the labor, such that you can identify when there's a problem occurring and make decision appropriately. Then some of the shortcomings of the Partograph is it is demanding. It requires time because you need to be plotting, and then most of the time there's lack of manpower, and then it requires the skill. You have to know how to plot the Partograph for you to be able to plot it well and interpret it well. And then part of its advantages, it helps in simplifying, like handing overs when you are on call and you are handing over to the next team. Just by looking at the Partograph, you can quickly summarize, okay, this is so percent, this is how the labor is going. So these are some things about the Partograph. And then now we'll look through how to plot one, interpret, and then, but before we start, if there are any questions, before we start plotting this Partograph, if anyone has any question, please feel free. Let's address these questions before we start plotting it. So please unmute yourselves. Let's discuss, let's plot this Partograph together. So please, you can unmute yourselves. So is there any question? Should we go ahead and start plotting? Yes. You guys are not audible. Is there anyone with question, or should we just go ahead and start plotting?
Yes, we should just start plotting.
Okay, I will assume you said we should start plotting.
Yes, we should start plotting.
Okay, no problem. So for example, looking at this Partograph, let's plot this one and see how it goes. So I have an example here with me that says Mrs. AB, a 25-year-old gravida 2 para 1, whose hospital number is 321456, presented to the labor ward. Sorry, are you saying something? So she's Mrs. AB, a 25-year-old gravida 2 para 1, whose hospital number is 321456, who presented to the hospital on 10th of July 2023 at 10 a.m. with complaints of labor pains. So should we plot this information first?
Yes.
Yeah.
So of course, if you look at the Partograph, you have a place for the biodata where you write the name, the gravidity, the parity, hospital number, date of admission, time of admission of every patient, so that you don't mix someone's Partograph with another person's Partograph. So like this one now, for example, for example, this example said Mrs. AB. So you know her name is AB, Mrs. AB. A gravida 2 para 1. So gravidity is 2. She's gravida 2 para 1. Hospital number, they said, is 321456. Admitted on the 10th of July 2023 at 10 a.m. So she came at 10 a.m. with complaints of labor pain. So you were the doctor that received her and you examined her and admitted her at 10 a.m. because when you examined her, you found out that she had a cervical dilatation of 4 centimeters. Membranes were intact. I always make sure that I write my timings so that I don't confuse it. So you know the time. She came at 10. So you know this is 10, this is 11, 12, 1, 2, 3, 4, 5 at least. Every small box here is 30 minutes. These 2 big boxes are an hour. So this is your first hour, second, third, fourth, fifth, sixth, seventh, eighth. Or you can write it either ways. This can be your first hour and this can be your 10 to 5. Either ways you write it, it's
I don't
still the same.
understand. Please, can you repeat the time again? You said
No problem. Let's see. So this is hours, how many hours she has been on admission, right? So
yeah.
assuming we take this time as the time she came 10, right? 10 a.m.
Yeah.
So this is the first hour.
Okay.
Then after 10, you have 11, 12, then 1 p.m., 2 p.m., 3, 4, 5. So this 11 is her second hour on admission. This is her third hour, her fourth, her fifth, her sixth, her seventh, 8th hour on admission.
Yeah.
Is it clear?
Yeah, it's clear now. Thank you.
Okay. So now that you have figured your timing, you know that she came at 10 a.m. And when you examined her at 10 a.m., she was at 4 centimeters cervical dilatation. So at 4 centimeters at 10 a.m., remember, if you plot your 4 centimeters here, is that 10 a.m.?
No.
That is 9:30. So your 4 centimeters is actually here, not here. Because if you plot it here, that means at 9:30, she was at 4 centimeters cervical. At 9, This is 9:30 and then 10. So this is where it should be. At 9 centimeters, she was at 4 centimeters cervical dilatation. At 10 a.m., she was at 4 centimeters cervical dilatation when you did VE. Then when you checked per abdomen, the descent was 4/5. Only 4 of your fingers were above the head of the baby per abdomen. So when you are to plot, you know that at that same time, you did your descent and it was 4. So this is descent, and you are supposed to denote it by a cycle, but you've already plotted your cervical dilatation with an X, and now you want to plot your descent. So there is no confusion here. This is your cervical dilatation. And then to show that there is descent occurring at the same time, you just cycle it. So you've denoted the cervical dilatation and the descent. Before we continue, any problem here?
No.
And then you examine, still on your VE, you found out that the membranes were intact. So of course you come here and you denote it with an I, that the membranes were intact. And then you checked the fetal heart rate and it was 130 beats per minute. So you still go ahead. This is our line. This is the line that we are plotting on. So you figure out 120. So this is 120 and you plot your heart rate there.
Is it 120 you said, or 130?
120. Sorry, 130. Yes. So you plot it by a dot at your 130. And like we said, if it is in between these two dark lines, it is within normal range. So far everything is going well. Of course, there was no molding. So if there was no molding, you write 0. And then you came to check for contractions. She was having 2 mild contractions. So how will we record mild contractions?
Excuse me, doctor. Please, can you allow the ones that are in the waiting room, the ones to join?
Okay, no problem.
Partograph maybe.
So now how will we denote that she's having 2 weak contractions in 10 minutes? How will we shade it on the partograph?
Yes. In the dot, right?
Yes. So we denote it by making dots. Of course, don't forget that everything we are plotting now should not go towards this side. It should be towards this side because this is our first hour. If we go this way, then we have entered the second hour. So she's having 2. If she's having 2 contractions, you make your dots. So she's having 2 weak contractions. And then, of course, she wasn't given any oxytocin, no drugs were given, but you checked her vitals and her BP was within normal range. It was 110/70. So you look for 110. Of course, always make sure that you are plotting on the same line. Don't go and plot something on this line, then you plot another one here, or you go somewhere here and plot. Everything should be on the same line. So if it is 110, this is our 110, and then 70. So you denote them with an arrow. Like this. And then you join. Then she had a pulse rate of 90 beats per minute. And like we denoted the fetal pulse rate, it is also denoted by a dot. So if she's having 90, so she's having a BP of 110 by 70 and a pulse rate of 90. Sorry, I saw some people join. You checked her temperature, it was 36.5. So you come here and write your temperature. Of course, you checked her urine as well. The volume was around 250 mils. Assuming she had 250 mils of urine, there were no acetons, no proteins. So these are your findings at admission. So let's do a quick recap. This was Mrs. AB, who is a gravida 2 para 1, whose hospital number is 321456, admitted on the 10th of July 2023 at 10 a.m. with complaints of labor pain. Even though you don't have a place to write the complaint, but you are the doctor, you know that, okay, if she's coming to the labor ward, of course she's coming with complaints of labor pain. So when you examination findings at admission, on vaginal examination, she was found to be 4 centimeters. She was found to have a cervical dilatation of 4 centimeters. Head was for fifth palpable. She was having 2 mild contractions in 10 minutes. Fetal heart rate was 130 beats per minute. Amniotic fluid membranes were intact. There was no molding. Her vitals were within normal range, BP of 110/70 and a pulse rate of 90 beats per minute. Temperature was 36.5. There were no proteins or acetons in urine. Total volume of urine was 250 mils. So just by looking at this, you have seen, okay, just looking at it, this is so person, she just came and this is what is happening. Then of course, so now, when will you do VE? When will the next VE be? When do you do the next VE? At what time? You have done it at 10.
And then after 4 hours, then.
Yes. So if you are doing it after 4 hours, meaning 1, 2, 3, 4, you see why it is easier for you to write your timing. You know that your next examination is at 2 p.m. That is when you will do another vaginal examination for her. So at 2 p.m., let me accept this one. So at 2 p.m., you did a repeat vaginal examination for this woman. And you found out that, okay, now she is at 9 centimeters cervical dilatation. So this is your line for 10, 11, 12, 1, 2. So you know you are plotting on this line. So now that you checked, she's 9 centimeters dilated. So you denote it here. You see why the line should actually be to the left of that line. It shouldn't come to the right or towards the actual line. So just by finding out that here it is like this, you know that this labor is progressive. So you found out that she's 9 centimeters dilated. Then the descent now is 0. So this is our descent. This is the at 2, it was 0. So you come to 0 and you cycle. So your descent will be coming like this, while this will be going like this. And then, of course, fetal heart rate was assuming 140. So you look. This is so this is our line. And this is 9. Then if the fetal heart rate was 140, you go to 140 and you mark. That is your 140. Then, so now that when you now did another VE, you found out that the membrane had ruptured and the amniotic fluid was clear. So you do not by a C. Molding was 3 pluses, or let's say 2. So you figured out your fetal heart rate, your amniotic fluid is clear, there's 2 plus molding, cervical dilatation is 9, descent is 0 by 5, and she's now having strong contractions. Her strong contractions, she's having 3 strong contractions. So you highlight, you shade. If she's having 3, so you highlight the boxes completely. So now the issue comes here. So this is where she was having weak contractions, and here you examine she's having strong contractions. So it is assumed that this space here is supposed to be this. She must have been having strong contractions for her to have achieved what she has achieved. So this will be a continuation of your strong contractions. But then don't waste your time in the exam to be shading all these boxes. If you come at 2 and she's having this 3, if you shade this 3 and you leave this place empty, nobody will catch you that you have not shaded this place. It is when you have finished and you want to beautify your partograph, then you can shade all these remaining places. But otherwise, you can leave them empty. So that is about the cervical dilatation. And then, of course, she's progressing well, so you don't need to give her any oxytocin. Of course, in between, she's receiving, you are giving her IV fluids. Maybe you decided, okay, let's give her 1 liter or maybe 500 mils. So you write it here, whatever one you give her. And then, of course, you will check her vitals again. You checked her BP and now it is 120. She's anxious, she's going to start pushing. So 120 by 80. And her pulse rate is around 100. So you plot again. Her temperature still within normal range, that's 6.5. No proteins, no acetons, volume still the same. But you have already emptied the other one, so she has made like 250 mils again. Actually, it should be more than 250. But assuming that is what was given. So now that she's 9 centimeters dilated, when is your next examination due? You've examined her at 10, which is at admission. Then you examine her at 2 p.m.
Partograph.
So when is your next examination? After 2 p.m. examination.
After an hour?
When will you examine her again? You've
So
examined
after
at
1 hour.
you've examined at 2. After how many hours?
1.
Why wouldn't you wait for 4 hours again?
Because she's at 9 centimeters.
Yeah. You have already reached 9 centimeters and you are expecting her to be full cervical dilatation in the next hour because you are expecting 1 centimeter dilatation each hour. So you examined her at 3. And when you examined her at 3, she's fully dilated. So she's here. She's fully dilated and she's having 4 strong contractions. She's having very good contractions. In fact, she has even started having the urge to push. So when you examined her at that time, everything was within normal range. And then in the next in the next hour, around 4 p.m., you were told that she has SVD of a live male neonate. Birth weight 3 kg. Apgar score
2.5 to 3 is okay.
is 3 kg. Don't worry, he's 3 kg. So Apgar score of 8 and 9. So this was a spontaneous vaginal delivery, a very smooth one. So before we proceed, is there anyone with any question regarding this? Anything that needs to be clarified? And of course, you will be checking your fetal heart rate more frequently, not every 4 hours. Ideally, you should have continuous monitoring with CTG, but that is not done. So with Partograph, at least you check every 30 minutes. Or if you are overwhelmed every hour, you listen to the fetal heart rate. So it will be more frequent than this. It should be something like this or upwards, but it shouldn't come below or above. So is there anyone that needs any clarification regarding this? Or should we continue? Sorry, are you unmuted? Are you muted? So does anyone need any clarification or we can continue?
Continue.
Can you hear me?
Yes.
Okay.
Yes, we can proceed.
So I assume there's no question. So this here is for us to interpret. It has already been given. It has already been plotted. So who is going to help us
Sorry, I have a question.
read this? Okay.
I was taught that the first plotting has to be on alert line. So I don't know if is it necessary
Yes.
or not. But I can see your first plotting was not on the alert line for the 4 centimeter.
The thing is, assuming you want it to be on the, if you want it, yes, it can be on the alert line. what you are wanting is it should not go to the right of the alert line. That is what you are afraid of. So let's assume now you want to plot this. This is what you mean, right? The one that we plotted here. So
Yes.
assuming you want to plot it here, that means this line, when you we said that she's at 4 centimeters cervical dilatation at 10. This is 9:30 if you remember. This is 10. So if you plot it here, this is actually 9 a.m. not 10.
Okay.
I don't know if you get what I mean, because
Yes, I
these two
understand.
boxes are the first hour. If it won't confuse you, you can plot it that way. But in order not to get the rest confused, that was why I didn't plot it this way, because we don't have boxes to back up. Assuming sometimes they will tell you, oh, previous to this, at 9:30, the fetal heart rate was assuming they said, okay, fetal heart rate was 130 at 9:30, and we started plotting, and we started at 8:30, for example, and we started plotting here as our 9. Do we have a box for 8:30? We don't.
Okay.
So sometimes you just have to look at the question and then figure out. But then everyone has a way he plots his or her own partograph.
Okay. Thank you.
You're welcome. So can we interpret this one? So this is another partograph of Mrs. A, who is a gravida 3 para 2 plus 0, whose hospital number is 7886, admitted on 12th of September 2003 at 5 a.m. She had membranes were ruptured at 4. So when she came, if you look at this, they didn't open from their timing. They opened the partograph at 9. That means when she came, she was not in active phase of labor. For them not to have opened the partograph at 5 a.m., they had to wait till 9 a.m., which is 4 hours. So at 9 a.m., they figured out that, okay, she had a cervical dilatation of 5. Fetal head was 3. Descent was 3. Amniotic fluid was clear. And there was 1 plus molding. She was having 3 moderate contractions every 10 minutes. And the fetal heart rate was 120. Her vital signs, she was having a BP of 120 by 70 and a pulse rate of 80 beats per minute. These are the pulse rates, and this is the BP. Then she had a temperature of 36.8. Urine volume was 200 mils, and protein and acetons were not detected. So that is her examination findings at admission. But then, for example, in the exam, it is hardly they will give you a question and say plot. Most of the time, they might just say, what is the fetal heart rate at 9? What is the fetal heart rate at 10 a.m. or 9:30? They'll just be asking questions like this. Or maybe they can say, plot the fetal heart rate at 9 or at 10. It's hardly that they will say, okay, plot an entire partograph or maybe interpret an entire partograph. It will mostly come as questions. What is the fetal heart rate at this time? What is the fetal heart rate at that time? So of course, they examined again after 4 hours. And she was at full cervical dilatation. Fetal heart rate kept increasing, but it was not going above the reference points. Amniotic fluid was still clear, molding was 1+, and the head was completely down, 0/5. And she started having 4 strong contractions. That means they were lasting more than 40 seconds. She didn't require oxytocin or no IV fluids were given or analgesia. Temperature still remained within normal range. Urine volume was still 140. And then, of course, then at 120, you examined her at 12. Then at 12, she was at full cervical dilatation. Then by 120, she delivered a live female infant who was weighing 2.8 grams, 2.85 grams. 2,000, sorry. So that is 2.8 kg. So this is also a normal partograph. Let's see if we have a complicated one. This one is also a normal graph. And this is the last slide. So is there any clarification, any questions? Anything to sort? Or is it clear? That is the end of the lecture. So is there anyone with questions, clarifications? You can unmute yourself and ask.
For the descent, can you please explain it again, please? The descent.
Okay, no problem. So descent is determined during abdominal examination. You place your hand on the lower part of the abdomen around the pubic area. You place your palm where you palpated the head of the baby, if you are able to palpate the head of the baby. So you place your palm over the head, and you will know that you are touching the head by feeling a globular structure down towards the pelvic area. So when you feel that, just like it is demonstrated here, you put your palm, these are your 5 fingers, and this is the head here. So if you put your palm and all your fingers can feel the globular structure, which is the head, that means the head has not descended into the pelvis. So that is 5/5, meaning all your fingers can feel the head. So that is where you have this 5/5. But assuming you put your finger and only 4 of your fingers could feel the head, so you say the descent is 4/5. And that way, if only 3 can feel, you say 3. If 2, you say 2, until you cannot feel the head at all per abdomen. So when you cannot feel the head at all per abdomen, then you say the descent is 0/5. That means the head has completely gone down into the pelvic cavity. Is it clear?
Yes, it's clear. Thank you very much.
So any other question, clarification? You can unmute yourself and ask.
Okay, if possible, can we have an example of the abnormal?
An abnormal partograph, right?
Yeah, yeah.
Let me see if I can find a picture of one. The problem is my device is just about to shut down. The charge is just 1%. Can I share an abnormal partograph in the WhatsApp group? And then if you have any clarification, please feel free to message me.
Yeah, thank you.
Because the device is going to shut down now.
So thank you very much, Dr. Mariam, for this wonderful presentation of Partograph. So we are going to take a 30 minutes break. When we come back, then we'll do the last MCQ session. Thank you all. Thank you, everyone.